So the danazole is a it's a androgen. So what does it do is the only one thing that you have to remember is it inhibits the LH surge. Okay, it inhibits the LH surge. So it has a mild anti estrogenic plus anti progesterone progesterone effect. Okay, so it has an effect on estrogen as well as the progesterone. What does it do is basically it will decrease the sex hormone binding globule. So since it binds, it also, like, basically what happens is it will decrease the sex hormone binding globulins. So what happens, the free testosterone will be produced. Basically, the testosterone, this testosterone, to move inside the body, it requires the sex hormone binding globulins. So what happens, since this sex hormone binding globulins has been reduced by this danazole, the free testosterone is been increased in the body. Since there is an increase in the free testosterone in the body, what happens in the females? They'll be hirsutism. They'll be having deep voice. They'll have breast atrophy. Okay, these are all because of the. It's because of this danazole. Okay, because of this testosterone, these are all things will be happening. Okay, so now this, what happens is this danazole that causes the endometrial atrophy in the endometrial implants because of its anti-estrogenic effect. Okay, so it will decrease the endometrial implants will be reduced. Okay, so now what is the dosage of this danazole? See here, for danazole also you have to remember the dosage. So danazole, what is the danazole dosage is basically 200 microgram. So 2 to 3 times you have to take for 6 months. What was the MCQ asked is 80% of implants. 80% of the implants will be reduced. 80% of the implants will be reduced. And but if you stop this drug, there will be recurrence. There will be recurrence. Almost kitna 30% recurrence will be there. Okay. So biggest disadvantage, matlab, the side effect. Already I've written the side effect because of the testosterone. The biggest thing is it will has teratogenicity. This teratogenicity is one of the biggest complication, where when you're giving danazole, you have to use contraception also. Okay. So that is an MCQ. So here in danazole, what is the MCQs they have asked is basically what does it do? It inhibits the LH surge. It has a anti-estrogenic, anti-progesterogenic effect will be there, and because of testosterone, they'll have these three conditions will be there, and it will decrease the sex hormone binding globulins. That's the reason why there will be increased testosterone. Dosage 200 mg, 2 to 3 times a day. 80% of implants will be reduced. This is also an MCQ they have asked. Recurrence also will be there up to 30%. Okay, and it causes teratogenicity. That's why you have to use danazole along with the contraception. Okay, there is one more drug that is called as gestrinone. This gestrinone is also like a danazole, but only difference is it's having a long half-life. Okay, so if you ask about what is the chemical composition of this danazole, the danazole chemical composition is basically, it is 17 alpha ethynyl testosterone. Okay, that is the composition of the danazole. Okay, so what are the other drugs? This question they have asked. Okay, what are the among the following drugs which is not given for the endometriosis? Then you should give. So what are the other drugs that come? Cabergoline 0.5 mg you have to give. Mifepristone already we have discussed, and anti tumor necrosis factor alpha, anti angiogenic angiogenesis, that is inhibitors, angiogenesis inhibitors, anti-immunomodulators, not anti-immunomodulators, it's the immunomodulators basically. Immunomodulators, what are the drugs? Pentoxifylline, pentoxy toxifylline pentoxifylline, okay, and estrogen receptor antagonist. All these drugs can be generally given. These are all extra drugs, okay. Now the surgical. What is surgical management? Guys, surgical management, I'll tell you, the surgery cannot be done. It is not like a cesarean section. Okay, you just do a uterus incision, take the baby and closure. This surgical management is individualized. Based on what? First thing, based on the family. That means whether she wants fertility or has completed family. Second, whether she has symptoms, it is mild or it is severe. Third, based on the location. Fourth, based on the age. Fifth, based on the severity of lesions. Okay. And last and more, the socioeconomic status. So based on all these factors, you have to what happens, you have to formulate a type of surgery that you have to do. Okay, so now for example, if there is a endometrioma, you have to do surgery. What is the surgery you have to do? Cystectomy, total. Okay, so in endometrioma you no need to do hysterectomy, whereas if the patient is the female, she is already 40 years of age, she has completed family, tubal ligation also done, so she has grade 3 lesions. So what is the treatment of choice? Then you have to go total abdominal hysterectomy, but bilateral salpingo-oophorectomy plus removal of endometrial implants. Okay, this is the treatment of choice. If it's a deep lesion, what happens? You have to do some of the extensive surgeries. What are the extensive surgery that is there? That includes DJ, stunting, and you have to do resection and anastomosis of bowel. So that is because the lesions, if it is there in that location, you have to remove all the lesions. Along with that, you have to do the anastomosis as well. So these are all the things that you have to do. That means this extensive surgeries is basically done for the grade 4 lesions. Okay, so when you're doing the surgery, you have to take a proper consent and you have to explain the risk and the benefit of that surgery for that patient. You have to take the risk as well as the benefit. So the patient should be benefited more than the risk. Then only you have to go for such extensive surgeries as well. In the case of the infertility, you should also explain the relatives or explain the patient, explain about the chances of the infertility more if you do endometrial surgery. That means basically this is a very important point you have to remember. For example, you are doing a surgery for endometriosis, endometrioma. Okay, that means in the ovary. Okay, there is a chances of, when you're doing laparoscopy, there is a chance of injury to the ovary. Once there's an injury to the ovary, what happens? That injury to the ovary, that leads to decrease in the anti-Mullerian hormone. This is nothing but called as ovarian reserve, na? It's nothing but called as ovarian reserve. If there is a decrease in the ovarian reserve, what happens? The chances of infertility will be increased. So you have to remember. So that you have to explain this. You have to explain this. Okay, that along with that, if the patient is some, for example, 30 years female, 30 years female is there. Okay, now in this 30 years female, so she has completed family, so you're planning of TH plus BSO. What is TH plus BSO? Total abdominal hysterectomy plus bilateral salpingo oophorectomy. So that means ovaries is removed, ovaries is removed. So what happens? She will have very early menopause symptoms. So for this, what happens? You have to advise this patient for hormone replacement therapy to prevent what? Especially vasomotor symptoms as well as the bone mineral density. Okay, so these are basically why I'm telling you all this is, if they're asking any question, for example, a female, she has come with the complaints of the chronic pelvic pain, and the laparoscopic findings are grade 3 lesions based on the American Society of Reproductive Medicine, ASRM. So now this patient has completed her family with the tubal ligation done. What is your mode of treatment? Then they will write, okay, you have to do bilateral salping oophorectomy plus TH, or just you have to do the endometrium surgery, or just remove the endometrial implants, or just give the pain treatment, all this. So then you have to see the lesions. If it's a grade 3 lesions, grade 4 lesions with the chronic when day to day our life is hampered, so that is also important. So her quality of life is reduced. Quality of life is reduced. Then you have to go for the surgery, explaining the cons of that surgery. For example, 30 years you want to do oophorectomy, then you have to tell all this. So early menopause, HRT, all these things. If there is an infertility, endometrioma surgery you are doing, then there's a chance of further increase in the infertility, because you might damage the ovary and the follicles will get damaged. So everything is interrelated, and you have to discuss and formulate one type of surgery and do it. Okay, so now, in the infertility, what you have to do? So I told you EFI should be used in the case of infertility. So infertility, you have to do EFI. What is EFI? Endometriosis fertility index. So based on that chart, you have to identify whether she is good or she is bad for the infertility. So in such type of people, what you have to do is, IVF, in vitro fertilization, you have to do. So in this, a GnRH agonist suppression is done with add back of 3 to 6 months before IVF has to be done. Before IVF, this is the important thing. GnRH agonist suppression plus 3 to 6 months of add back you have to give. Add back theory, that means I told you now, that is equine estrogen of 625 microgram and norethistron should be given for this patient, okay, to increase the pregnancy outcome. So how will you do? So ovulation induction, obviously, ovulation induction, or controlled ovarian hyperstimulation. If there is decrease in follicles, then we do this. So IUI, IVF, ICSI. Okay, this is the algorithm. Okay, so now, what is the pre and post-op management? Pre and post-op management of the surgery. See, when you're doing any surgery for endometriosis, pre-operatively you have to give some drug. Just like malignancy, you give chemotherapy so that you decrease the size of the lesions, and then you do surgery. It's the same here also. You give some of the drugs to decrease the size of the lesions so that the surgery will become easy for them. What is the drug that you give? We give GnRH agonist. I told you GnRH agonist. What is the agonist? all renin, goserelin, buserelin, naferelin, so leuprolide, everything you have to use for this surgery. That means before surgery. So what happens is that will reduce the size and the extent of endometriosis. Okay. So now the surgery becomes easy. So now the surgery will happen, and after that, what happens? Post operative also you have to give GnRH for 3 to 6 months. If you are giving more than 6 months, obviously you people are very pro in that. You have to give add back with estrogen. That you have to remember. Okay, so that's about the surgery. Now recurrence. See, this endometriosis is the condition where there is a high chances of recurrence. But on what basis the recurrence? Is it same for all the patients? No, it depends on the multiple factors. First thing, for example, you are doing TH plus BSO. In this, recurrence will be very less. If you are doing only endometrial implants, you are removing endometrial implants removed, then recurrence will be less, but still more than this. So when compared to this, it will be more. And some of the endometrial implants you have removed partially, so recurrence will be high more than this. Okay, so like that, based on every conditions, based on whether the surgery was done completely, partially it was done, or a hysterectomy was done, so only the visible lesions are given, the deep seated lesions are not removed. So based on everything, the recurrence rate will be generally changing. Okay, so if any patient, for example, if there's a chance of recurrence, so what happens is, first in few years, first 1 or 2 years, the chance is 5 to 20%, but next 5 years it will reach up to 50% of the recurrence. Okay, now now just now I told you, so in this partially if you removed matlab, it indicates it's a severe lesions, right? It's a severe lesions. So now you can tell in grade 3 as well as in grade 4 the recurrence rate is very high, because there is a chance where we cannot remove few lesions, or sometimes we can overlook. So the deep seated lesions will be there, or overlooked lesions. So because of this, there might be chances of recurrence. Okay, so in the recurrence cases, we have to use LNG IUCD for almost 24 months. You have to use. So for dysmenorrhea as well as for the recurrence to be prevented, you have to use this one. Okay, so treatment for recurrence, medical treatment, Dynogest. We know that Dynogest. What is the dosage? You must know orally, daily, orally. You have to give for 6 months. Or GnRH agonist can be given. So if infertility is not maintained, IVF can be tried for these patients. Okay, that's about the endometriosis. Now recently there are few things which has come into the endometriosis in adolescence. Endometriosis in adolescence. What is endometriosis in the adolescence? It's an ES yesterday 2022 they have asked questions, important. So since it's important, we'll discuss some 3 to 4 points, not more than that. See, in the adolescence, if you're seeing this endometriosis, first and foremost, you have to ask what are the things. First thing, in very early, she's getting all this endometriosis, very like in adolescence. So first thing is, you have to ask about the family history. Family history you have to ask. If there is any outlet obstruction, I told you endometriosis can be occurred because of the retrograde flow. That was the Samson series. So you have to ask if there is any obstruction because of like intact hymen or vaginal stenosis, cervical stenosis, so like that. So anything which is preventing the outward flow, that also you have to ask. Third, in these patients you have to give transvaginal scan, you have to do, so that this will give a proper orientation about the where is the location and how you have to go for it. Okay, with TVS scan if you're not able to identify, then you have to do MRI. Okay, so trans-abdominal scan you could do, transperineal and transrectal, everything, all the things can be done. So now, all after doing this, if she is having still lesions after giving medical treatment also, then you have to do laparoscopy, and that biopsy should be done of the lesions, and that should be sent for the histopathology. Okay, so now what is the treatment for this? Treatment for adolescents is we have to give hormonal contraception or progesterones. That's what now I told in the previous class. So first is for pain in a series, and after that oral contraceptive pills, and then progesterones have told, so that you can give. And now, very in the very rare case, this is rare case, you can give even GnRH agonist with so much caution, because in the very early age you are giving GnRH agonist. This also can be done. Okay, and next, scar endometriosis. Scar endometriosis, basically what happens, you think the abdomen is like this. Okay, so there's a scar. What happens on the scar? There is a endometrial implants. Okay, this endometrial implants will be like a fleshy mass. So sometimes you might also think it must be a malignancy also, because it's not healing. So recently I saw a patient. So she told she has undergone cesarean section 6 months before, and now she has told this lesion is there. Since 6 months, this lesion is there. So one thing is, okay, this must be an endometriosis, and second thing is a malignancy. How do you rule out based on the history of this whether it's a endometriosis or malignancy? Is this endometriosis will have a classical symptom that she'll have pain during cycles. During cycles. So she'll tell the lesions will be so painful during my menstruation. So that's a classical symptom that she will tell. It's not a hard and fast rule, but still almost 50-60% they will tell. And that patient who has come to OPD, she was telling that during cycles her lesions will become so tender. It's very painful, especially during menstruation. So she herself was presuming that maybe because of the contraction of the uterus that pain is happening of the lesions. No, it's an endometriotic tissue that is there. Okay, so why does this happen? If she's undergone any previous surgery, during the surgery, if she is fiddling with any endometriotic tissue, and if there is no proper closure, or if there is no proper cleaning of the abdomen before the closure, that endometrial implants iatrogenically you can implant on the skin. So that is the reason why they'll have scar endometriosis. Okay, that will have a scar endometriosis. So now, what is the treatment for this scar endometriosis? For example, there is a scar endometriosis. You have to do wide excision. For example, this is the like lesion. This is the transverse curve, and this is the endometrial tissue here. So this will be like a tender nodule which is not healing for almost some few months. Then what you have to do is you have to do a wide excision, and then you have to send for the biopsy. This everyone knows. And now what next happens is, what is the treatment after this? For scar endometriosis, you have taken the lesion. Is that the treatment? No. You have to again give that treatment. What is the treatment? Gold standard Dynogest. Kitna dosage? 2 mg. So twice you have to give for 3 to 6 months. Okay. You can also give GnRH agonist. I don't want to confuse you. Dynogest, you remember Dynogest. Okay. So the last topic of the endometriosis that we are going is newer advances. This will be asked in your university exam. Recent advances they might ask. So here there is something called laparoscopic helium plasma coagulation. So what happens is this ionized beam of this helium gas. So what happens is this ionized beam of this helium gas, this will vaporize endometrial tissue, endometrial implants. Rather, I would tell it's implants. So this endometrial implants, what happens is it will basically vaporize them with this temperature. So this technique is comparatively better than diathermy, than diathermy. Why? Because remember, this will have very precise precision will be this. That means there will be less lateral burning. In diathermy, what happens if you're taking this lesion here, it may affect this other regions also. But here, this helium gas, this helium gas, whatever the vaporization you are using, that will have a precision. That means exact location it can hit rather than causing trauma to the other structures. So this is what happens is it's still coming up with the modification. It is not come to the market yet. But remember, it has its own complication, that is especially dreaded complication, that is helium embolism. Helium embolism. Okay, so this is about the newer advances, that is basically the helium vaporizer or helium coagulation, helium plasma coagulation. And there is one small flow chart. We'll go through that flow chart. It is an important flow chart. We'll see what is it. Okay, so this is the flow chart for the endometriosis. So, if the clinical suspicion of the endometriosis is there, that is a chronic pelvic pain, dysmenorrhea affecting the quality of life. That's what I told you. Dyspareunia, GI symptoms, urinary symptoms, infertility. Okay. So now I told you two major complaints of endometriosis, and that is pain and that is infertility. Okay. If there is infertility, what will you do? You have to do a diagnostic and operative laparoscopy, and along with that ovulation. I told you ovulation induction should be done, IVF, IUI, anything, any modality can be used. So okay, so if the fertility is priority, what happens, especially wherever there is a endometrial tissue, only that ablation you are doing or removing the endometrial tissue, uterus and ovary you are trying not to disturb more, because the fertility should be preserved. So excision and ablation of plus adhesive lysis do not offer hormonal treatment. Superovulation with the IUI with IVF, and then if there is a recurrence, definitive surgery should be done. Medical management with LNG IU intrauterine device can be done. But for example, pain, mild pain, moderate pain, you again have to go for diagnostic and operative laparoscopy. Mild pain, you can just give a short trial of NICDs. Okay, so second line is GnRH agonist or antagonist aromatase inhibitors. Okay, so now these all things we have discussed: agonist, antagonist, aromatase inhibitors, androgens, all that. Now, if fertility is not preserved, what happens is, now if there's a peritoneal endometriosis involving bladder, bowel, ureter, everything, so you have to give hormonal treatment, you have to give GnRH, everything, and then decrease the size of it and go for the definitive surgery. Okay. In the case of adolescents, I told you, adolescents, what is the drug that we give? Oral contraceptive pills we give. Okay, that's what I told you now. In the adolescents, see, that is what we give. The same thing here they have explained. Adolescents, you have to give the contraception. For pain, NSAIDs. If not relieved, GnRH agonist, but this is very rare. That is what I told you here also. Very rarely give GnRH agonist. So these are all the things, these are all the MCQs, guys. This is endometriosis is filled with MCQs. So potential space for the MCQs. And you have to give add back theory for 1 year. Why? Because this patient is very young and you have to start the add back theory as soon as you start with the GnRH. With add back theory for 1 year you have to give. Recurrence, if it is there, medical treatment. I told you in recurrence you have to give LNG. Recurrence LNG should be done for 24 months. That means for 2 years you have to give. The same thing they have given here. Recurrence, you have to give LNG or oral contraceptive for 24 months. And if it's surgery, TH plus BSO with removal of all the endometriotic lesions. Okay, so here only I have told. Where did I explain that? TH plus BSO plus, see here, TH plus BSO plus removal of the and all the endometrial implants. So this is about the endometriosis, and this is a very important topic. That's why I've told you in and out of this topic. So if my videos are little lengthy, you can watch it in 2x and 3x, and you can just go for the revision. This will be of a great help to you. And thank you. And I'll be uploading the other topics also, the new topics also, for your NEET PG, for your university of PG exam, as well as for the UG exam. UG exam, this might be little extensive, but still you can make a notes of it, make it minimalize this, and you can write it in your university exam. So these videos will be of a great help, and if you like it, just subscribe it, and I'll be uploading the many videos as possible. Thank you so much. Take care.